Hi guys, so let us discuss about tuberculosis today. So entire the microbiology or the mycobacterium tuberculosis, the entire information regarding that, as well as the anti-tubercular drugs which are used in treating the tuberculosis. So let's get started. So the tuberculosis which we have, the causative organism of tuberculosis is nothing but we have Mycobacterium tuberculosis, or we have this mycobacterium which is there, which causes the mycobacterium tuberculosis, which causes the tuberculosis infection. So it has a unique property. As you can see, it has mycolic acid in the cell wall, so which causes or which is responsible for the acid fastness of the mycobacterium that we have. So what is this acid fastness per se? So it's nothing but, as mentioned here, it's acid resistant. So normally we use acid to kill the bacilli or any bacteria, but there are certain bacteria like we have mycobacterium which is acid fast, that is resistant for with the acid, right? Then the integrity of cell wall, these two are responsible for the acid fastness of the mycobacterium. Then we have who isolated it. So let's discuss about some history regarding the mycobacterium. So the Robert Koch is the one who isolated the mycobacterium. So he is the one who isolated the mycobacterium. Then we have the classification here. So the mycobacterium can be classified into three groups. As you can see, we have Mycobacterium tuberculosis complex, Mycobacterium leprae, which is also called as Hansen's bacilli. Then we have non-tuberculosis mycobacterium. So based on the morphology, the Mycobacterium tuberculosis complex can be divided into two different bacilli, that is Mycobacterium tuberculosis as well as Mycobacterium bovis. So this bovis we get it from the unpasteurized milk. As you can see, it is acquired from the unpasteurized milk, and it causes only the 5% of the infection, whereas the 95% of the infection is caused by Mycobacterium tuberculosis. Now let us discuss about the morphology of the Mycobacterium tuberculosis. So this, you can see the morphology of Mycobacterium. So yeah, so we have mycocytes as the outermost layer. We have mycolic acid, arabinogalactan, peptidoglycan layer, lipoarabinomannan. It has a very much important role with respect to the pathogenesis, and also we have cell membrane. So in order to remember this morphology or the contents or the what are the layers of the cell wall, we have a mnemonic with us, that is PAMI had OP poisoning. You can see. So here P stands for peptidoglycan, A stands for arabinogalactan, M stands for mycolic acid, which is responsible for the acid fastness of the Mycobacterium tuberculosis, and O stands for outer membrane. The outer membrane consists of glycolipids, glycoproteins and lipids, and P stands for protein, that is lipoarabinomannan, which is responsible for the pathogenesis of Mycobacterium tuberculosis. Then other P here, it stands for porins. So these porins are very much important, and they are present in this morphology of the Mycobacterium tuberculosis. Now let's discuss about the pathogenesis of the Mycobacterium tuberculosis. So for this, we have to first discuss about the source of infection. So we have the human source as well as the bovine source. The human source, the organism which is responsible for it is Mycobacterium tuberculosis, whereas the bovine source, we have Mycobacterium bovine or bovis. So it is by the unpasteurized milk. So what is the mode of transmission? As is here mentioned, the inhalation is the most common mode of transmission. So what is the meaning of it? Like ఒక పర్సన్ ట్యూబర్క్యులోసిస్ ఇన్ఫెక్షన్తో ఉన్న పర్సన్ వచ్చి ఇక్కడ దగ్గిపోతే ఒక కొన్ని అవర్స్ దాకా ఆ బ్యాసిల్లై అనేది ఇన్ ద ఫార్మ్ ఆఫ్ ఏరోజోల్స్ దే విల్ బి ప్రెసెంట్ హియర్ ఇట్ సెల్ఫ్. So again, if you come here and if you inhale those aerosols, you are also susceptible for the infection. That's the meaning of this here. So the aerosols which are there, they will be persistent in the air for several hours. Then second mode of transmission is ingestion. So in the pediatric population, what happens is the children most commonly they swallow the sputum. So as a result, what happens, this ingestion is also a mode of transmission in the pediatric population. Then the third mode of transmission is inoculation. What is the meaning of inoculation is there is a direct skin to skin contact. So if you have the direct skin to skin contact with the infected person. So this causes the inoculation, which is the other mode of transmission. Then we have what are the risk factors of it. So the risk factors, you can see the for the sputum test to be positive, we have more than 10 power 4 bacilli per ml should be present. If there are cavitary lesions, as you can see, then the bacilli should be more than 10 power 5 to 10 power 7 bacilli per ml. Then we have the other risk factor that we will study in the SPM, the overcrowding and poorly ventilated areas. As you can see nowadays, there is a commercialized buildings where in a small space there are more building or more rooms that are allocated, and if a room is designed for two persons, then only two persons uh, should be present there. If there are more than two persons here, then what happens is there will be overcrowding. So మనం ఇందాకే చూసాం the mode of transmission. This is because of the inhalation. So ఒకవేళ two persons are in more close proximity, there is a more chance of transmission of this infection. Then there is a low cell mediated immunity, as in case of the TB that we have. Then we have other So we have other comorbid conditions like post-silicosis and post-transplant. So these all things, they point to the same thing, that is lower the cell-mediated immunity. Then we have age and gender here. So the age is extremes of age, as in case of like old age people or very small age people. So in order to prevent like old age or very young or newborns, so in order to prevent this, as India is endemic for the tuberculosis, we will give the BCG vaccination. In the vaccination topic that I have discussed in previous video, I have discussed about the BCG vaccine, which is given intradermally, right? So gender also, we have males in the old age, whereas females for 25 to 34 years. Then let's go to the pathogenesis. So in the pathogenesis, we have various steps that are enlisted here. So first step is droplet nuclei. As in case of the mode of transmission, the droplet nuclei which are present in the air, they are being inhaled. So not all the inhaled droplet nuclei enters the alveoli. It is mentioned that less than 10% of the bacilli enter the alveoli. So after entering the alveoli, there is another step, that is adhesion to the macrophage. So this is mediated by the lipoarabinomannan, as mentioned here. So this lipoarabinomannan and it attaches to two receptors, that is mannose receptor as well as the complement receptor. And third step is the phagocytosis by macrophage. So it is enhanced by the C3b. And then the third and fourth important step, that is lipoarabinomannan mediated survival inside the macrophage. Generally what happens, the macrophage which is there, it just engulfs the bacilli and destroys it. But in this case, it's not happening. It kills the macrophage, that our macrophage is defeated in presence of this tuberculosis bacilli. So what happens here is, normally inside the macrophage, what happens is the phagosome which is there, this phagosome is being fused with the lysosome to form phagolysosome. This lysosomal enzymes, they kill the bacilli. So here the lipoarabinomannan which is there, its main function is to inhibit the fusion of this phagosome with lysosome. Then the bacilli multiplies inside this and ruptures the macrophage and releases the bacilli. And this bacilli which are released, these are going to infect more other macrophages and causing the infection to spread, right? Then what is the role of immunity here? So the role of immunity is very much in case of this tuberculosis infection, where we have the T helper cells that we have, they differentiate into Th1 and Th2 and Th17. Whereas the Th17 is for acute and chronic infection that we'll study in the pathology that we all know. Whereas Th1 differentiated cell is being produced, releasing the interleukin-2, interferon gamma, as well as TNF alpha. So the TNF alpha is basically recruits the fibroblasts. So are you remembering of something else that you study in the pathology? Yes, that is the chronic inflammation which is mediated by the Th1 differentiated cells. So there what happens is the interleukin 2, it recruits the lymphocytes, interferon gamma, it activates the macrophage into the epithelioid cells, and the epithelioid cells, they fuse to form the giant cells, and then TNF alpha, it recruits the fibroblast, and entirely it forms the granuloma. Yes, when we heard the term tuberculosis, definitely we'll remember about the granuloma. So same thing here. So the tubercle formation, that is macrophage, there will be activation, classical activation of macrophage, and there will be hard tubercle and soft tubercle formation. So hard tubercle, it just kills the bacilli, whereas soft tubercle, we have the caseous necrosis in the center, which is a characteristically seen with the tuberculosis. Now what happens, there is a tissue damaging response here. Can you guess which type of hypersensitivity reaction? Yes, it is type 4 hypersensitivity reaction, or delayed type of hypersensitivity reaction here. Now what happens is, this delayed type of hypersensitivity reaction, it damages the soft tubercle, and what happens is, the caseous necrosis matter that is we have, it is released here, and it is spread directly, or it may be spreading hematogenously causing the miliary TB, or it may be spreading lymphatic, in the lymphatic routes also it may be spreading, right? We have three different routes. And we have Th2 response, that is Th2 differentiated cell, it releases the interleukin 4, 5 and B cells. So it is basically responsible for the humoral immunity, which is having very much low or no role in case of tuberculosis. Now let's discuss and briefly about the role of host immunity here. So you can see the role of host immunity. The T helper cells, they are differentiated into Th1 cells and Th2 cells. Th1 cells, again they have giving two different phenomena. One is tubercle formation, which is a positive sign for our immunity. So we have hard tubercle, soft tubercle. In hard tubercle, it just kills the bacilli, and in soft tubercle we have caseous necrosis in the center. Whereas the tissue damaging response with the Th1 differentiated cell is nothing but a delayed type of hypersensitivity reaction, or it is a delayed type of hypersensitivity reaction, or a type 4 hypersensitivity reaction. So it causes the release of the caseous necrosis matter, and it may spread directly, or it may spread hematogenously causing miliary TB, or it may spread in a lymphatic fashion. Th2, it's B cell differentiation, it has no role in tuberculosis, or very minimal role, that we'll just ignore it for now. Next we'll go to the clinical manifestation according to the NTEP guidelines, that is National Tuberculosis Elimination Program Guidelines 2020. The symptoms of active TB include, so the symptoms of active TB include, first thing is cough, and then if you have fever, classic fever, that is the patient tell that ఈవినింగ్ రైజ్ ఇన్ టెంపరేచర్ వచ్చి, సార్ నాకు దగ్గుంది 3 వారాల నుంచి, లేదా గత 3 వారాల నుంచి అట్లా దగ్గుంది నాకు చాలా, అండ్ సాయంత్రం అయితే చాలు నాకు అంతా జ్వరం వచ్చేస్తుంది, అసలు మొత్తం ఫుల్ అంతా వేడిగా అయిపోతుంది అంటాడు. అండ్ దెన్ వీ హ్యావ్ వెయిట్ లాస్, అండ్ వీ హ్యావ్ లాస్ ఆఫ్ అపటైట్, అండ్ చెస్ట్ పెయిన్ వైల్ బ్రీతింగ్ ఆర్ కాఫింగ్, అండ్ నైట్ స్వెట్స్, chills, as well as fatigue. So these are the things that we will see with respect to active TB. So these are the symptoms that we will see in the active TB. Then we'll go to the clinical manifestation. So clinical manifestations, TB, we have two different things, or two different ways it can present. One, it may be the pulmonary TB that we have, or extra pulmonary TB that we have. So in pulmonary TB, we have two different presentations. One is primary and other one is secondary. So what do you understand by the word primary? So the word primary here, it means there is an initial exogenous infection. So for the first time a person acquires the infections exogenously. Exogenously means from outside, right? So it occurs mostly in the children, and there will be Gons focus here. So this Gons focus is very important. So Gons focus is nothing but the fibrotic nodular lesion that you will see. Yes, so this is the fibrotic nodular lesion that you will see in the Gons focus. And what is the primary complex then? So primary complex is nothing but the Gons focus, which is having the hilar lymphadenopathy. So Gons focus plus hilar lymphadenopathy together called as primary complex. What is Rekes complex then? The primary complex which is there, it is calcified. So it is calcified to form the Rekes complex. So this is what you have in the primary pulmonary TB. So in primary pulmonary TB, it involves the subpleural spaces. You can see below the pleura, this space is being involved here. That is the fibrotic nodular lesion, the Gons focus, and it involves the middle and lower lobes. So it involves the middle and lower lobes. So this is all about the primary pulmonary TB. Now let's go to the secondary pulmonary TB. What happens in secondary pulmonary TB is, it is the exogenous reinfection. So it's second time again it's coming, and or it may be the endogenous reinfection or reactivation of the endogenous infection, right? It mostly affects the adults, and we have Simon's focus here. So what is this Simon's focus? So Simon's focus is nothing but hematogenous seedling in the upper lobe, right? So it means there is a hematogenous seedling in the upper lobe which is called as Simon's focus. Now what is the Asman's focus? So Asman's focus is nothing but the reactivated Simon's focus along with central caseation. And in the secondary pulmonary TB, we have the posterior and apical regions of the upper lobe are most commonly involved. Okay, now let's summarize the pulmonary TB in a jiffy. So we have the pulmonary TB, we have primary pulmonary TB as well as secondary pulmonary TB. In primary pulmonary TB, we have to remember three terms. One is Gons focus. So the Gons focus is nothing but the fibrotic nodular lesion, and we have primary complex, which is nothing but the Gons focus with hilar lymphadenopathy. Then we have Recky's complex. So this Recky's complex is primary complex which is calcified. And the primary pulmonary TB involves the middle and lower lobes most commonly, and also the subpleural spaces are being involved. Now let's discuss about secondary infections or secondary pulmonary TB. It is the exogenous reinfection or endogenous reactivation of infection. It mostly involves the adults, as well as we have Simon's focus as well as Asman's focus. Simon's focus, it is hematogenous seedling in the upper lobe, and Asman's focus is reactivated Simon's focus with central caseation. So this completes the pulmonary TB. Now let us discuss about the extrapulmonary TB. So in extrapulmonary TB, what is the thing that you will listening so many times about TB? So TB infects every part of the body except hair and nail, because they are not living, right? So it infects every part of the body which are living. So first we'll discuss about skeletal system. So in skeletal system, it has a part spine, right? It has part spine. Whereas in skin, we have scrofioderma as well as lymph nodes. That is, in scrofioderma, it involves the lymph nodes. Whereas apple jelly nodules that we have, that is lupus vulgaris. So it involves skeletal system, skin, and from head to toe. Now let's go. First, meningitis, lymphadenitis, that is upper respiratory tract infection, pleural. So here I forgot about upper respiratory tract infection. You just add it. And we have pleural effusion, pericardial effusion, GIT, and genitourinary tract. And we have miliary TB, that we have disseminated TB and aspergilloma. So if you count, you have to remember that 11 should be there. We have skeletal system, skin, meningitis, lymphadenitis, pleural effusion, upper respiratory tract infection actually. So we have 1, 2, 3, 4. And here upper respiratory tract infection 5, 6, 7, 8, 9, 10 and 11. Yeah. So we have this 11 extrapulmonary TBs. What are 11 extrapulmonary TBs? Repeat after me. So first we have skeletal system, part spine spondylitis of TB. Then skin, we have two presentations, scrofioderma, that is lymph node lymphadenopathy or lymphadenitis. Then we have apple jelly nodules, lupus vulgaris. Then we have meningitis that you will see, and lymphadenitis, upper respiratory tract infection, pleural effusion, pericardial effusion, GIT, and we have genitourinary tract infection and miliary TB, that is disseminated TB and aspergilloma. So you have this diagrams here. As you can see, this is the scrofioderma that you see. You can easily appreciate it. See, that is the lymph node which is you can see. And these are the apple jelly nodules that you will see in case of this lupus vulgaris. And then we have part spine or tuberculosis spondylitis that you can see here, right? So this is what you will see. And now let us discuss about the laboratory diagnosis. So in laboratory diagnosis of Mycobacterium tuberculosis, we have these 5 things that we need to follow. First, we have to demonstrate the bacilli in the lesion by microscopy, then isolating in the culture, then serology, molecular methods, and demonstrating the hypersensitivity reaction to the tuberculin protein. Now let us discuss about the collection of sample. So what is the blunders that we should not do with respect to the collection of sample? We should not do the blood culture for Mycobacterium tuberculosis. That's the first point. And we should not collect the swabs. Why we should not collect the swabs is, since the Mycobacterium tuberculosis is a lower respiratory tract infection, majorly it's a lower respiratory tract infection, we should not collect the swabs, right? And then we have a pulmonary TB. So in pulmonary TB we have a sputum. So as usual, you can know we have the sputum sample, how we have to communicate with the patient to collect the sputum sample, that all you will know in the practical aspects of microbiology. Now the sputum sample, we collect the two sputum samples here. First one is you will collect the spot sample. That is, as soon as the patient comes to you with the symptoms of Mycobacterium or tuberculosis, you just ask the patient to give the sputum sample. So that's the spot sample, and you indicate the patient that you have to come tomorrow morning also to give the sample. That is the early morning sample. So why you are collecting the early morning sample is, the early morning sample, as we are sleeping overnight, the respiratory secretions will be pulled up and there will be increased bacillary load, so that we can easily detect the bacilli or the Mycobacterium tuberculosis. And for extrapulmonary TB, we have CSF sample, urine sample, BAL, that is bronchoalveolar lavage, or pleural fluid, pericardial fluid, or peritoneal fluid. We can collect anything, right? We have discussed all the extrapulmonary symptoms or extrapulmonary TB. So this urine sample is 24 hours urine, and we have to collect at least 3 consecutive days 1 liter of the sample. Why we have to collect this 1 liter of urine sample for 3 consecutive days is, the bacilli which are there, they are released intermittently in the urine. They are released, so the bacilli are released intermittently in urine. So this is what you have to understand with respect to the urine sample that we need to collect. And then the B step that we have to going to do here is, we have digestion, decontamination, and concentration. So why we have to digest? We have to digest the thick pus cell that we have. For that we have digestion. Then decontamination. We have any method you follow, there will be definitely the contamination with the normal flora that we have in our oral cavity. So we need to kill the normal flora. For that we have the decontamination. Then we have the concentration to increase the yield, right? These are the 3 steps that we have to follow. The concentration methods that we follow, we have 2 different methods. As you can see, we have Petrov's or modified Petrov's method, as well as N-acetyl L-cysteine method. So this Petrov's method, we have 4% NaOH that we use. This 4% NaOH that we use is used to kill the normal flora. Here we use 2% NaOH, and this is to increase the yield of Mycobacterium tuberculosis. Now let us discuss about the direct microscopy that we have. So what is the advantage of direct microscopy? It is cheap, and it's rapid, and it is easy to perform. See, an undergraduate second year student like us, we are also able to perform the ZN staining, right? In our microbiology practical aspects, we are performing ZN stain. So it's such an easy to perform, right? So that's why advantages are cheap, rapid, and easy to perform. Disadvantages is it is less sensitive. So it is less sensitive, as well as another important disadvantage is we cannot detect the viability. So we cannot detect the viability here. So that is a very important disadvantage regarding it. And now we have the ZN staining. What is the staining method used? Yes, that is the ZN staining that we are very much fond of. So in the ZN staining, what is the interpretation? You will see the long, slender, beaded, acid-fast bacilli in the blue background. That is a red colored bacilli in the blue background. That is the interpretation that we learned in the practical aspects of microbiology also. So what are the modification of that? We have Kinyon's cold acid-fast method, as well as the fluorescent stain, that is auramine, rhodamine, which is specific for the Mycobacterium tuberculosis than the ZN stain. These things you will learn by heart for practical aspects, for microbiology practicals. That's I am very much sure about. Then we have the NTEP guidelines for the grading of ZN stained sputum smears. So what are the guidelines that we have? So if we have to first oil field immersion, we have to screen 100 oil field immersion fields. If there is a no acid fast bacilli, then we have to report it negative. So if we screen 100 oil immersion fields and you saw 1 to 9 acid fast bacilli only, then we have to report it as scanty, but we have to report it as positives only. Then if you see 10 to 99 oil immersion field for 10 to 99 acid fast bacilli for 100 oil immersion fields, as you can see, then you can report it as positive, that is 1 plus. Then you have 1 to 10 oil immersion bacilli per oil immersion field, you have seen 50 oil immersion fields, then it is 2 plus positive. And if you see the more than 10 acid fast bacilli per oil immersion field and you have observed 20 oil immersion fields, then you can see for one oil immersion field you are having more than 10 bacilli and you have examined 20 oil immersion fields. That is, consistently you are having more than 10 bacilli per oil immersion field. Then it is 3 plus grade and it's very much high bacillary load. Now we have culture, we have this liquid medium that we have, that is MGIT, which is definitely a viva question in the microbiology practical. What is the liquid medium for Mycobacterium tuberculosis? You have to answer it, that is Mycobacterium growth indicator tube. That's very important. We have conventional culture methods as well as automated culture methods. First we will discuss about the conventional culture methods. So what about this conventional culture methods? So in conventional culture methods, we have time it takes is 6 to 8 weeks. It's a very laborious process, right? Nobody is waiting for it. Now, if you just tap it, you are getting the food online delivery. So who are very much patient to wait for 6 to 8 weeks? And also it's a very serious infection. We need to treat it immediately. So the culture, conventional culture is being used just for confirmation. That's all. We are not waiting for treatment for this conventional culture reports nowadays. So the doubling time, it's very important. You have learned it in general microbiology also. Doubling time of E. coli is 20 minutes. Doubling time of Mycobacterium is 10 to 15 hours. Exactly. And then we have advantages. It is specific. It indicates the viability. It's not like unlikely the ZN stain, which doesn't indicate the viability. And it also helpful for the drug susceptibility test. The only disadvantage is time. So time it takes 6 to 8 weeks. Oh my god, it's very huge time. So the medium used here is Lowenstein junction medium. It's a very much selective medium for Mycobacterium tuberculosis. And also the colonies, this is a definite question that the examiners will ask. So what are the colonies that you will see in the Lowenstein junction medium? We will see the rough, tough and buff colonies. And then we have the automated culture mediums, and for this the 2 to 4 weeks that we have. So we have the 2 to 4 weeks that we have, 3 to 4 weeks time taking for the automated culture medium, and the growth is faster as compared to the conventional culture medium. And it is a disadvantage is only one thing, that is expensive. It is somewhat bit expensive than the conventional culture medium. Now the identification, culture identification that we have, the culture identification that you can do is by Malditov. That's our favorite. For everything we'll write the Malditov itself in the microbiology. It's okay. And the MPT 64 antigen detection by immunochromatographic test. So it is also a culture identification method. And then we have the molecular method. So what is the gene that we detect? Here it's mentioned. So it is JS6110 gene. So it's a gene that we detect. We have 3 different methods that we have: CBNAT or gene expert, then TrueNat or chip based TrueNat, and then we have line probe assay. So what is the principles of all those things? First we have CBNAT. The principle of it is real time PCR. Chip based PCR, as the name indicates, is a chip based. And line probe assay, first we have the DNA extraction, and then we have the multiplex PCR, then we have the drug susceptibility testing for the line probe assay. You can see. So what is the turnaround time? The TAT here mentioned is turn around time. So what is the turnaround time for TrueNat? It is 1 hour. Whereas for CBNAT it is 2 hours. Whereas for line probe assay it is 2 to 3 days. So you can see the broad, that is the classification of the molecular methods here. You can see. So the molecular methods take less time than the culture. We all know that. We have CBNAT or gene expert. The full form of it is cartridge based nucleic acid amplification test. TrueNat or chip based, and line probe assay. So these are the things about the molecular methods. But in case of the extrapulmonary tuberculosis or pediatric population, we directly jump into the CBNAT. We doesn't waste our time with the culture or staining. We directly jump into the molecular method, that is CBNAT. Now let us discuss about the tuberculin test or Mantox test. So this Mantox test is nothing but we inject the purified tuberculin antigen and we observe after 48 to 72 hours. If there is an induration more than 10 mm, then definitely it is indicative of the host immunity, which is cell mediated immunity, is good. So what are the false positives and false negatives for it? Just imagine just put your pens down and just imagine what are the possibilities of false positive here. So we are testing the immunity. So it may be the recent immunization with the BCG vaccination, maybe a reason for the false positive, or there may be non-tuberculosis mycobacterium infection. So these are the two reasons for the false positive that you can see. And false negative, there may be decreased immunity as in case of HIV, or there may be early infection or advanced infection, or there may be miliary TB. So these are the responsible for false positive and false negative. So this is the jiffy of the tuberculin skin test or Mantox test, which is very important test to be discussed. Then we are here. So we are now going to discuss about the pharmacology aspect or the anti-tubercular therapy. So let's dive into it. So you can see it's anti-tubercular drugs. So I have taken this image from the KD Tripathi. So we have the first line drugs and second line drugs. First line drugs are HRZE as mentioned here clearly, that is isoniazid, rifampicin, ethambutol, pyrazinamide, streptomycin. It's previously mentioned in the first line. Now it is not a first line drug. It is kept as a reserve drug in the injectable drugs. And second line drugs, we have fluoroquinolones, we have moxifloxacin, levofloxacin, ofloxacin, ciprofloxacin, and other oral drugs like ethionamide, prothionamide, cycloserine, para-amino-salicylic acid, rifabutin, thiacetazone. So we'll discuss all of these drugs. Now let's discuss about the peculiar features of Mycobacterium tuberculosis with respect to the treatment or drug or drugs, right? So we have rapid growers, we have slow growers, sputters, and dormant. So you can see this rapid growers here. So these rapid growers are nothing but they are having the fast growth and they are present on the cavity. So this is the cavity that we have. So they are present on the cavity and they are extracellular. Whereas the slow growers are the intracellular and they are present inside the macrophage. Then we have intermittent growers or sputters. So these are very much important. These are present in the caseous necrotic matter that we have. So then we have the dormant forms. They do not grow for the long time, and then there is a time. When there is a time, it gets activated. That is what time? That is decreased immunity. When the immunity is decreased, then these dormant forms, they become active and they cause the infection. So this is a note point that is very important to understand. The bacilli continuously shift from one population to other population. So you have to understand this note point, very much important, because 1 minute. 1 second. So yeah, this is what we have note point here. Yeah. Okay. So this note point that we have is very much important, because when we are aim to treat the rapid growers, we will give one type of drug. But we should not give only that type of drug. That's why we have the first line regimen, that is HRZD regimen, because we need to treat all these forms, because we don't know in which form does the bacilli is. It may be in the rapid growers for some time, it may shift to the slow growers, or it may go to the sputters or intermittent growers, or it may go to the dormant form. We don't know. So we have to treat all the forms. So how to treat a TB patient? So let's get into it. So first, a patient will come to you with the sputum test positive or chest x-ray result positive, and the symptoms are also there, like we have discussed the active TB symptoms like cough, fever, night sweats, all those things are present, weight loss. So what to do? Should we ask the patient to go for the drug susceptibility and we have to treat? No. First line therapy should be started immediately. Immediately the patient comes, you have to start with the first line therapy, that is HRZD. Then you will order the drug susceptibility or drug resistant testing using the CBNAT or line probe assay or TrueNAT that we have discussed, the molecular methods. So this detects the TB is there or not, and also the drug susceptibility for rifampicin, isoniazid. So Now we have two outcomes here. Either it may be susceptible to it or resistant to it. So if it is susceptible or sensitive, then continue with the first line, no problem. So if it is resistant, there comes the problem. If it is resistant, then it comes under the drug resistant tuberculosis. So we have the very much guidelines that are laid by the National Tuberculosis Elimination Program to treat this drug resistant TB. Let's discuss about it. So this drug resistant TB may be of two forms. One is multi-drug resistant TB and extensively drug resistant TB. Definitely in the microbiology or in pharmacology practical viva, they'll definitely ask about the definition of this multi-drug resistant TB as well as extensively drug resistant TB. ఏమీ ఉండదు. మల్టీ డ్రగ్ రెసిస్టెంట్ టీబీ అంటే ఇప్పుడు ఫస్ట్ లైన్ డ్రగ్స్ ఏవైతే ఉన్నాయో రిఫాంపసిన్ అండ్ ఐసోనియాజిడ్, ఈ రెండిటికి రెసిస్టెంట్, ఈ రెండిట్లో ఏదో దానికి లేదా రెండిటికి రెసిస్టెంట్ అయి ఉంటే ఇట్ ఈస్ కాల్డ్ అస్ మల్టీ డ్రగ్ రెసిస్టెంట్ టీబీ. అట్లా కాకుండా ఎక్స్టెన్సివ్లీ డ్రగ్ రెసిస్టెంట్ టీబీ అంటే ఫస్ట్ లైన్ డ్రగ్స్ లైక్ రిఫాంపసిన్ ఐసోనియాజిడ్ రెసిస్టెంట్ ఉంటూ ఫ్లోరోక్వినలోన్స్, వన్ ఆఫ్ ద ఫ్లోరోక్వినలోన్స్ కి రెసిస్టెంట్ అయ్యి యాజ్ వెల్ యాజ్ లినజోలిడ్ ఆర్ బెడాక్విలిన్. సో దీస్ టూ are basically belongs to the group A drugs. We will discuss what are these group A drugs, group B drugs and group C drugs. We have three groups, group A, group B, group C. We will discuss about it. So now let us discuss about firstly the multi-drug resistant TB. So how to treat it? So we have two regimens. One is short-term regimen, that is 9 to 11 months regimen. Other one is long-term regimen, the 18 months regimen. See, the TB is a very important disease to be treated because India is endemic for the TB and we need to treat the TB as early as possible. We will discuss about it in the SPM also. SPM lo kuda third year lo definitely ga TB paina, it's a very important topic because it's a burning topic in India. We have been fighting against it since decades, but still we are not able to get out of it. So the short term regimen, that is 9 to 11 months regimen, we have both intensive phase and the continuation phase. In the intensive phase, that is 4 to 6 months, we will give the Bay-Klep. So these are the drugs that we will give in the intensive phase, that is for the 4 to 6 months. So what are the drugs that we will give in the intensive phase? It is Bay-Klep. So you can see the Bay-Klep here. What are the drugs? That is bedaquiline, E for ethionamide, I for isoniazid. Even though it is resistant, we will give high doses. Then C for clofazimine, E for Klep, Cl, L for levofloxacin, and E for ethambutol and P for pyrazinamide. Whereas for continuation phase, for 5 months, we will go with Klep. We will remove the Bay and we just give the Klep. That is clofazimine, levofloxacin, ethambutol and pyrazinamide. So these are the drugs that we will give in the 9 to 11 months regimen. Now let's go to the 18 months regimen. So same in the 18 months regimen also we have intensive phase as well as continuation phase. So in the intensive phase for the 6 months we will give first line drugs, that is LLB. Not first line, sorry, it's a group A drugs, that is LLB. We have linezolid, levofloxacin as well as bedaquiline, and we have cycloserine and clofazimine. So these are the group B drugs. So we will give group A and group B drugs in the intensive phase of 18 months regimen. Whereas continuation phase we will just go with this linezolid and levofloxacin, and you will go with cycloserine and clofazimine, these two drugs, but we will not go with bedaquiline. Why we will not go with bedaquiline, I will discuss when the individual drug we are discussing. Then we have for the extensively drug resistant TB, we have a regimen, that is BPAM regimen. So for this BPAM regimen is given for the IPD patients, that is when an IPD patient comes to you, inpatient department, then we have this bedaquiline, pritomanid, linezolid and moxifloxacin. So this is recently added. Previously it was BPAL regimen. Now this M is added to form the BPAM regimen. That you need to remember. So this is a jiffy how to treat a patient with tuberculosis. You can see. So first you need to go with the first line therapy, drug susceptibility, susceptible, resistant, multi-drug resistant, extensively drug resistant, 9 to 11 month regimen, 4 to 6 months of intensive phase, 5 months of continuation phase, 18 months regimen, 6 months of intensive phase and 12 months of continuation phase, and extensively drug resistant TB we have BPAM regimen. So this is the overview of treatment of tuberculosis. Now let us discuss about individual drugs, or first we will discuss about the groups I have discussed about you. That is the group A drugs, we have linezolid, levofloxacin, bedaquiline. Whereas group B that we have is cycloserine and clofazimine here. And we have group C, all other drugs like amikacin, streptomycin, delaminid, pretomanid, and ethionamide, ethambutol, and we have imipinum and meropenem. So what are the goals of chemotherapy? So we have three important goals of chemotherapy in TB. First thing is we have to kill the rapidly dividing bacilli in order to cure the infection and in order to stop the spread of infection. As in a heavily populated country like India, we not only treat the infection but also we need to stop the spread of infection, right? So for this we need to kill the rapidly dividing bacilli, and we have to kill the persistent bacilli in order to cure and prevent the relapse. In order to prevent the relapse, we have to kill the persistent bacilli and also prevent the emergence of resistance. For that case, we have the regimens like HRZD regimen, the first line drugs. We give all the combination of drugs. We not give only one drug, right? So this is then we go the first line drugs, that is isoniazid. First, for every drug, we will go and discuss about the dose. Here the dose of isoniazid is 5 milligram per kg body weight. This is the dose of isoniazid, and then we will discuss about some important points regarding it. It is primarily tuberculocidal. It affects both extracellular as well as intracellular bacilli, and it kills the extracellular bacilli, whereas it just inhibits the slow growing bacilli. That you need to remember. Whereas for non-tuberculosis mycobacterium, it has no effect. That you need to remember. Then mechanism of action, you can just remember this one line if you forget everything that I will discuss in now. First, you have to remember basics, like at least you have to tell, it is at least you have to write or tell, or you have to know that it inhibits the mycolic acid synthesis. So what is the mechanism of action is, this isoniazid is actually a prodrug and it is converted into the active form with the help of this enzyme, that is we are having the Mycobacterium catalase peroxidase enzyme. From where does this Mycobacterium catalase peroxidase enzyme get? That is from CAT-G gene. So this Katrina G gene, that's a way to remember. So this gene, it is responsible for coding this Mycobacterium catalase peroxidase enzyme. Now what happens, this active form of isoniazid, it complexes with NAD as well as NADP. So this NADP that we have, it's a coenzyme for dihydrofolate reductase, you can see. So that's why it inhibits the DNA synthesis also. But this is a minor form of mechanism of action. The major form is this. The NAD, it inhibits the beta ketoacyl ACP synthase. So with the help of the gene that we have here is ACP, as the name indicates, beta ketoacyl ACP synthase. So we have KAS, ketoacyl ACP synthase A gene. So this is responsible for inhibition of mycolic acid synthesis, and also another one, that is acyl carrier protein reductase, which is coded by INHA gene. So these two are responsible for inhibition of mycolic acid synthesis here. So these two are responsible for inhibition of mycolic acid synthesis, and thereby they are responsible for destruction of cell wall as well as they are tuberculocidal. So mechanism of resistance, as you can understand this pathogenesis or mechanism of action, not pathogenesis, sorry. As you can understand the mechanism of action, you can easily know what is the mechanism of resistance. Because of this CAT-G gene mutation or Cas-A gene mutation or inhibin A gene mutation. Because of these three genes mutation, there is the development of resistance. You can see here. This is a very important thing to be discussed with all of you. Then pharmacokinetics, we have orally it's well absorbed, but the metabolism, which is very much important here, by acetylation. So we have SHIP group of drugs which are undergoing this acetylation. In that, the I stands for isoniazid. You all know the SHIP group of drugs which are going in this isoniazid is a very important drug. So this is happening with the help of enzyme N-acetyltransferase 2 enzyme. So we have two different group of individuals. One may be either fast acetylators, other maybe they are slow acetylators. Fast acetylators, they have more amount of N-acetyltransferase and the T-half will be less, that is 1R, and they are more directly causing the hepatotoxicity. Whereas the slow accelerators that we have, they have low amounts of N-acetyltransferase. The T-half will be more, that is 3Rs, And also the peripheral neuritis that we have, it is the most common side effect with this slow oscillators. The Indian population that we are coming under this slow oscillators group. That's why we have very much commonly associated peripheral neuropathy with the isoniazid treatment. So interactions, we have aluminum hydroxide, the antacid, which is responsible for the inhibition of absorption of isoniazid, and it's a potent enzyme inhibitor, right? So it, since we have, wait one second, right? So it's a potent enzyme inhibitor along with rifampicin. So it's an enzyme inducer. Both are in the first line drug, right? First line drug therapy. So these two cancel out each other. It's an enzyme inducer, it's an enzyme inhibitor. Both are cancelling out each other. And then side effects, you all know the peripheral neuropathy. So what is the reason for this peripheral neuropathy? One is it increases the excretion of vitamin B6 and it prevents the conversion of the vitamin B6 into the active form, that is pyridoxal phosphate. It is inhibited by the isoniazid. So these two are the reasons for the peripheral neuropathy caused by isoniazid. So vitamin B6 for prophylaxis we will give 10 milligrams per kg. For treatment we will give 100 milligrams per kg. It is associated with the hepatotoxicity, xerostomia, and also important thing, that is decreased, or we are having the gynecomastia and peripheral neuropathy, and we have so these are the side effects which are responsible for the isoniazid, right? So it is also responsible for decreasing the seizure threshold, which is very important side effect. So threshold, sorry. So it is responsible for decreasing the seizure threshold, which is responsible for increasing the seizure activity. So these are the side effects, like we have peripheral neuropathy, hepatotoxicity, and xerostomia, decreasing seizure threshold, and we have gynecomastia and also peripheral neuropathy. These are the side effects. Now let's go into the second drug that we have is rifampicin. Rifampicin is very important, and we have NEET PG 2025 question also here. We'll discuss about it. So first we'll discuss about the dose here. What is the dose we have is 10 milligram per kg body weight will give rifampicin, and it is also the primarily tuberculocidal, and its efficacy is similar to that of the isoniazid. It is effective as that of isoniazid and for the tuberculous bacilli. So it is a semi-synthetic derivative of the rifamycin, and it is derived from the Streptomyces mediterraneae thing, right? So it is effective for many other bacilli, not only the Mycobacterium tuberculosis. So this is the basis for the NEET PG 2025 exam. That is, we have burn lamp, the mnemonic to remember. So first thing we have is brucellosis. In brucellosis, the treatment or drug of choice is doxycycline plus rifampicin. So it's a treatment of choice. Then L stands for Legionella as well as leprosy. A stands for anti-tubercular drug as well as Staphylococcus aureus. M is very important, and it's a NEET PG 2025 question that you can see here. So it is used for the prophylaxis of meningococcal meningitis. The question was, what is the drug that is used for the chemoprophylaxis of meningococcal meningitis? We have given a case, like you have the neck stiffness and all the symptoms of meningitis, and they are pointing towards the meningococcal meningitis, and they are asking the chemoprophylaxis for this meningitis. So the options were like ampicillin, doxycycline, and some other thing, and rifampicin. So do remember, rifampicin is used for the prophylaxis of meningococcal meningitis. Very important. Then we have, it is mainly useful for the slow growing or sputters, slow growing bacteria or intermittently dividing sputters, and for non-tuberculous mycobacterium it is also effective for them also. What is the mechanism of action? As I discussed previously, the single line that you need to remember, it inhibits the beta subunit of DNA dependent RNA polymerase. As a result, what happens? The name indicates the DNA dependent RNA polymerase. As a result, there will be inhibition of RNA synthesis, there will be cell death, and there will be bactericidal effect that you will see. So next we have a mechanism of resistance, that is because of the RPO gene. You can see the RPO gene that we have. So because of this RPO gene, the resistance is being developed to rifampicin. Pharmacokinetics is orally well absorbed, food inhibits the absorption, And CNS, though it crosses the meninges, but there is a P glycoprotein, that is a efflux protein, that decreases the level of this rifampicin in the CNS. So it is a potent enzyme inducer, and this is again another NEET PG 2025 question. So what happens in this is, they have asked the TB patient. So the TB patient has, so the HIV patient is diagnosed with TB, as it's the most common opportunistic infection. So how do we proceed? We have to give first the ART or ATT. So that's the options there. So do remember, when the HIV patient is diagnosed with TB, definitely first we have to start with ATT. First start with ATT, and after 2 weeks then you go with HIV, that is ART therapy, right? So first you start with ATT and then you go with the ART therapy after 2 weeks of treatment with the ATT. And we have to prevent, why we are doing like this is to prevent the iris, that is immune reconstitution syndrome, that we'll discuss later. So what are the side effects of this? There are common side effects like hepatitis. When dose is less than 600 milligram per kg, this side effect is infrequent. And we have cutaneous flushing, flu-like symptoms, and most common and most favorite side effect of examiners is a red orange discoloration of the secretions like urine and eyes. So definitely in your MCQs or in Viva, they will definitely ask about this. We need to inform the patient that no worries, it's just a normal thing, it doesn't harm you. So we need to tell that the colorations, there's a discoloration of the urine and other secretions. So that's a responsibility of ourselves to inform the patient regarding that, right? And now we have discussed about the pyrazinamide, the third first line therapy. So with respect to pyrazinamide, the dose is very high, that is 25 milligram per kg, and it is more active in the acidic medium, as you can see, and it's only effective for the intracellular bacilli, and by killing the residual intracellular bacilli, it is responsible for the sterilizing effect, right? Then we have mechanism of action. It is basically the passive diffusion into the bacilli, and the pyrazinamide is being converted into the active pyrazinoic acid, as you can see, with the help of this pyrazinamadase enzyme, which is coded by Priyanka A gene. It's a way to remember, that is PNC A gene, right? Mechanism of resistance, simple, by mutation of this PNC A gene. And side effects, similar, most hepatotoxic, and it inhibits the uric acid excretion, thereby it may precipitate the gout. So if gout is precipitated, immediately stop this pyrazinamide and increase the duration of treatment to 9 months with the HRE, that is isoniazid, rifampicin and ethambutol, and it is avoided in pregnancy. So it's a very important to be remember. So which antitubercular drug is avoided in pregnancy? It's a MCQ. Definitely it's a pyrazinamide. Now let us discuss about the ethambutol that we have. The dose is 15 milligram per kg here, and it's primarily the tuberculostatic. It's the only primary or first line antitubercular drug with tuberculostatic property, and it affects the fastly multiplying bacteria, and atypical mycobacterium are also inhibited by them. And what is the mechanism of action? It inhibits the arabinosyl transferase enzyme. The only one thing that you remember, if you forget anything, that is inhibition of arabinosyl transferase enzyme. Thereby it inhibits the arabinogalactan, inhibits the cell wall synthesis, and inhibits the incorporation of mycolic acid into cell wall. This is the main mechanism of action, thereby it is tuberculostatic. A mechanism of resistance, that is MBBS gene mutation. And what is the uses of this is first line therapy in the ATT, added with clarithromycin and rifabutin for Mycobacterium avium intracellular, that is MAC complex infection, which is an opportunistic infection in the HIV patients. So what is the treatment of a MAC complex infection in HIV patient? You will add the ethambutol along with the clarithromycin and rifabutin. Then we have side effects, loss of visual acuity. So the mnemonic or the way to remember is the E that we have here. E stands for eye, right? Like that you can remember. The side effects of them are loss of visual acuity or color vision, red green color blindness, and also retrobulbar conjunctivitis. Hyperuricemia, it may precipitate the gout. So then we have streptomycin. The dose of it is definitely 15 milligrams per kg, and it is not a first line drug now. It is kept as a reserve drug, as an injectable. Mechanism of action, it belongs to the aminoglycosides. So it has protein synthesis inhibitory property. So it acts at the 30th ribosome. We have aminoglycosides as well as tetracyclines which are acting at the 30th ribosomes, inhibiting the mismatching of amino acids, and it inhibits the protein synthesis. So it acts exclusively at extracellular bacilli. What acts exclusively as intracellular bacilli? Yes, we have discussed it previously. The pyrazinamide, it acts exclusively with the intracellular bacilli. It's very important to remember. For extracellular bacilli, we have streptomycin, and resistance is a gene that is responsible, that is RRS gene. Side effects: ototoxicity, nephrotoxicity, and neuromuscular blockade. Because of these side effects, because of these side effects, they are contraindicated in pregnancy and myasthenia gravis, you can see. Then we have these are the aminoglycosides which are there, same. Fluoroquinolones, we have moxifloxacin, levofloxacin, and ofloxacin, my little orphan. So you can remember, it's a way to remember. So moxifloxacin is used for extremely drug resistant TB, levofloxacin for the multi drug resistant TB, ofloxacin for the leprosy, right? We have to remember it. And these are the regimens where the levofloxacin is used: CLEP, the L for A, and here the group A drugs, and B palm. M stands for moxifloxacin here. So what are the side effects? Side effects, as usual, we have nausea, vomiting, photosensitivity, tendinitis, and tendon rupture is the most specific side effect with the fluoroquinolones. Nephrotoxicity, except with the p-floxacin as well as moxifloxacin, that is PM. Then we have the mechanism of resistance because of the mutation of the genes, that is gyrase, since they are inhibiting the DNA gyrase. So gyrase A and gyrase B gene. We have ethionamide, which is a static drug, right? Mechanism of action, I have discussed while discussing the morphology. I have discussed about mycolic acid. It's a unique property of the Mycobacterium tuberculosis. So this ethionamide as well as the first discussed isoniazid, these all are mainly, and ethambutol also, are mainly targeting the mycolic acid synthesis, or anyway they are inhibiting the mycolic acid incorporation into cell wall. Thereby they are inhibiting this tuberculous bacilli, right? So it comes under the second line treatment of the anti-tubercular drugs, and it is for the short regimen of multi-drug regimen, multi-drug resistant TB. You can remember the Bay clip, that is the short term 9 to 11 months. So in the intensive phase, that is for 4 to 6 months, you will go with the ethionamide. Side effects: nausea, vomiting, and diarrhea. Neuropsychiatric side effects is very much common with this ethionamide. Decrease in BP and hepatotoxic are also the side effects. And thionamide, since ethionamide, the name indicates here ethionamide, so it is having the similarities with the thionamide, which is an anti-thyroid drug. So it is responsible for the hypothyroid goiter as well as impotency, which are side effects regarding the thionamide derivative, since it's thionamide derivative. Next we have cycloserine. It's an antibacterial and it acts by inhibiting the cell wall synthesis, and it belongs to the group B drugs. I have discussed again already about the group A, group B, group C. It is primarily tuberculostatic. So what is the mnemonic to remember the tuberculostatic is? We have PECT. So PECT. P stands for para-aminosalicylic acid, E stands for ethionamide, and another E stands for ethambutol, and C stands for cycloserine and thiacetazone. So these are the drugs we are going to discuss now. So side effects of this cycloserine is again neuropsychiatric side effects. We have two drugs which are associated with neuropsychiatric side effects. One is ethionamide, second one is cycloserine, and we have headache, convulsions, somnolence, and also peripheral neuropathy. We have para-aminosalicylic acid. It's a first effective anti-tubercular drug that is discovered, and mechanism of action: it inhibits the dihydroterate synthase inhibitor. So it's a static drug. It is associated with high GI intolerance, and it's having a poor compliance, right? So it is having GI side effects like nausea, vomiting, and diarrhea. So it's having bodily discoloration like eye and skin. So it's responsible for the bodily discoloration. Since it's a para-aminosalicylic acid, so it's responsible for it. Then we have linazolid. That is, it acts by the inhibiting the protein synthesis by binding to the 23S subunit of 50S ribosome, right? So it is having high bioavailability, approximately 100% bioavailability, and it comes under the second line anti-tubercular drug, and it comes under group A drugs. And you have side effects. Most common is bone marrow suppression and decreasing in the platelet counts after 7 to 10 days after starting the therapy, right? Then we have peripheral neuropathy, and it's associated with the MAO-A inhibitor, so or MAO inhibitor, which is responsible for the serotonin syndrome also. Then we have thiostazone, which is a static drug I have discussed already. It's the only drug that is contraindicated in the HIV patients, and it interferes the mycolic acid of the Mycobacterium tuberculosis. Side effects, we have several or fatal, severe or fatal skin reaction, ototoxicity, hepatotoxicity, and bone marrow suppression. We have bedaquiline. The mechanism of action of bedaquiline is it inhibits the ATP synthase, and also it is a cidal property. And second line anti-tubercular drug, it is useful in the multi-drug resistant as well as extremely drug resistant TB. High volume of distribution. Why? Because it is having the redistribution property. T-half is approximately 160 days. What is the meaning of it? So if you stop the bedaquiline now, it is present in your plasma till 160 days. So that's the meaning of it. And as you can see, the name Q, so it's mainly associated with the cardiotoxicity, QT prolongation, given not beyond 6 months. That's why I have mentioned there. In case of the long regimen of the this multi-drug resistant TB, long regimen 18 months, 6 months intensive phase, we will go with LLB. But in the next 12 months continuation phase, we are not giving the bedaquiline. This is the reason for that. It's associated with the cardiotoxicity. That's why we are not giving it. So cross resistance with the clofazimine is being noted because of we have ATP synthase mutation or efflux that is common for the clofazimine as well as this bedaquiline. Side effects, these are common for this bedaquiline and the next discussed drugs, that is pritomanid and delamanid. So QT prolongation, hepatotoxicity, and electrolyte imbalance, these are the side effects of them. Delamanid and pritomanid, so they inhibit the so they destroy the mycolic acid synthase per se. This is because of by free radical generation. So this is an important mechanism of action. So side effects same, QT prolongation, hepatotoxicity, and electrolyte imbalance. So these are the individual drugs. So I have completed the entire chemotherapy of this tuberculosis. You can see I have completed entire chemotherapy of it. So I have discussed about the first drug isoniazid. Here you can see, and I have discussed about the rifampicin. You can see, and I have discussed about the pyrazinamide and ethambutol and streptomycin, then fluoroquinolones, ethionamide, cycloserine, para-aminosalicylic acid, linezolid, thiostazone, bedaquiline, and delamanid and pritomanid. These two are the new group of drugs that are discovered, that is bedaquiline and pritomanid and delamanid. Now we will discuss about the HIV in TB, or HIV plus TB actually, not HIV in TB. So TB in HIV, you can tell like that, because TB is the most common opportunistic infection in the HIV infection. So we have for HIV infection TLD regimen, that we all know the TLD regimen. So we have for TB HRZD regimen as a primary or first line regimen. So we have this HRZD regimen. In that, rifampicin is the potent enzyme inducer. So that's why we should not use with the dolutegravir, because it's a substrate for CYP3A4. We should not use this dolutegravir along with rifampicin. So either we have to double the dose of dolutegravir, or we need to change this rifampicin to rifabutin, which is having lower enzyme inducing property, right? And we have to use the cotrimoxazole with the TB patient, with the HIV patient which is diagnosed with TB, since this decreases the risk of pneumocystic girovacci infection, which is the most common parasitic opportunistic infection in the TB, in the HIV again. So this is used to decrease the mortality as well as morbidity in the HIV infection. So these are the entire thing about the I think so this is the entire thing about the TB, right? So I think so I have given a brief idea regarding the tuberculosis infection. We will discuss a vast or a far more about it in the medicine as well as in the SPM, because in SPM we have so many programs that are introduced in order to eliminate and in order to just in order to eliminate the tuberculosis, right? So I think so this is all about the tuberculosis that we have. Thank you.